Hello and welcome back. In this lecture, we're going to be talking a little bit about public health interventions. So I know that you're in this class because you're really interested in trying to do something to actually produce a better health out in the world. Now, the research indicates that there actually are a bunch of different ways that we can actually be more effective in achieving those goals. And during this lecture, we're going to be talking a little bit about some of the strategies that you can use to ensure that you're actually producing the greatest benefit for the effort that you're putting in. All right, so what are interventions? Interventions are really any effort that's really trying to focus in on a target population, sometimes at an individual level, sometimes at a group level, to influence them in some way, helping them make better decisions or changing their behavior or anything where you're trying to shift something, perhaps changing policy. These are all things that you can do to change health status in the world. Now, in the Regal-Pittman textbook, there's a few different ideas around what different types of interventions, the levels at which different interventions can occur. So there's an idea of primary prevention or primary interventions. And these are interventions that are really aimed at removing underlying causes for a disease and to make you more capable of resisting a disease if you're exposed to it, potentially. And this is really interventions that are focused in on health determinants, for example. Secondary interventions are really thinking about taking people who've already been exposed to a risk and decreasing the probability that they would actually go on to develop a full-on disease. This is after they've been exposed to something, but before they've actually started developing symptoms of that disease. So here we're looking at addressing those risk factors, perhaps treating them. So you might treat something like hypertension to prevent somebody to moving on to heart disease, getting heart attacks. And you also might screen a population to make sure that they, to see who is at greater risk for disease and prevent that disease from progressing. So that's secondary prevention. Then we have tertiary prevention. So tertiary prevention is after people have already started developing symptoms of that disease. Well, there's things that you can do to delay or prevent the progression of that disease to be more severe. Or for certain people who have diseases, you can make efforts to actually prevent the additional complications and perhaps help restore function for those individuals. So when the question is, who are you targeting? Well, that's going to vary depending on what you're trying to accomplish. There are certain circumstances in which it makes the most sense to talk to people as individuals and really focus on them and their individual behavior and do that for a bunch of different people on an individual level. Sometimes you'll do interventions that targets a specific at-risk group. So if you're thinking about certain types of breastfeeding for children and helping ensure that infants get good nutrition. Well, you might want to target mothers in that circumstance. So focusing in on a specific group that might benefit from this particular health information. Then you can also have interventions that are really focusing on the general population. And this would relate to interventions where you're really trying to help everybody. And everybody can benefit from this information. So there's a bunch of different ways that you can approach actually accomplishing these goals. So sometimes you do things like provide people with information. So your hope there is that they get this information about risk or information about new strategies and behaviors, and they'll then adopt that information and actually change their behavior to decrease their risk. Another way to do things is to actually motivate people to change their behavior. So this could be general encouragement, but it can sometimes be financial incentives. For example, some health insurance companies will actually offer you money or savings if you actually adopt certain types of health behavior that decrease risk, like exercise or getting regular checkups. And then you have things like obligation. Well, you can actually require that people do things or fine people if they don't. So an example of this would be seatbelt laws. So if you don't wear your seatbelt, well, you might get pulled over. And that's the consequences of not doing the thing that's a recommended behavior in health. Now, these are just 3 different examples, but there are actually a wide range of different ways that you can actually approach addressing change in the community. I show this slide here because I want you to think about this, how this all combines together. When you're thinking about something that you want to do to improve health, the truth is that you're going to have a lot of different options. And you're going to have to make some decisions about where your time and energy is best spent. Now, you can think about this in terms of the levels at which you target people, whether you target individuals or organizations or communities or the entire populations. You can also think about where you're going to try and focus your efforts. Sometimes it makes sense to do primary prevention, where you're focusing more on determinants of health or things like that, really far upstream of a disease. Or sometimes you're really focused in on somebody who already has a disease and you're really trying to help them prevent the progression of that disease. So you can make decisions based upon what you think would be most effective in terms of where you want to target this health impact. And then there's always lots of different ways that you can go about doing this. You can have flyers. Sometimes you want to provide information about things. Sometimes you want to pull people into different programs where you work with them in an intense way and help them to understand how to improve their health behaviors. Some interventions are in the clinic. So maybe it's has less to do with changing someone's behavior. Maybe it's changing clinician behavior. Maybe it's creating structures so that when people come into the clinic, they feel welcome. That could be a really important public health intervention, particularly, for example, for people who speak other languages. You might want to create opportunities for folks and translation of key materials so that people have access. Or you might think about addressing this more at a policy level. Maybe what we need is new laws or rules, or changes in how we allocate funding to ensure that we have the resources we need to improve public health. So the point here is that, you can do these things using different methods. So you can change individual behavior at a policy level, or you can change individual behavior by handing out a pamphlet. The same thing with communities or looking at societies. So there's a lot of different options when you think about approaching a public health intervention. And that's actually really fantastic, because the truth is that the world is incredibly complex, and you're going to have to think really carefully and be really smart in order to pick the approach that's going to be most useful for people. All right, so let's talk a little bit about how we used to think about public health interventions. And the reason I want to do this is because there's actually a more modern approach to this that I think has helped us to create better public health interventions. But let's go back to the 1970s and how public health interventions were often designed in those situations. Well, you start out with figuring out who you wanted to talk to. So let's go back to that example of mothers, right? So say you want to help mothers to provide breast milk for their children. Well, you might target that, figure out that that's your target group, and you figure out where you're going to do it, and you then figure out what the needs are of the mothers to actually be able to do that. Maybe they need more time, or stations where they can pump milk, for example, right? So what are the needs of that population? Then you come up with what your goals are for your intervention and create an approach. Then you try it out with a few people, pilot test it. Pilot testing means to do an initial run to try and see whether or not it works. You then fiddle around with it a little bit to see how you can improve it based upon that initial experience. Test it again, and then go and do it out in the real world. And then you evaluate whether or not it worked. So that's how public health interventions used to be done. Well, what we're finding is that public health interventions, unfortunately, when you take this as an approach and then you just try and adopt it. So somebody does a public health intervention like this and publishes it, and then people try and do it themselves. Well, the truth is, unfortunately, it often doesn't work, right? So in this example that I just show here, what we're finding is that for a lot of new medical scientific discoveries, it takes a really long time to go from getting that initial information to actually integrating that into healthcare practice. And in fact, most of these discoveries that have a lot of promise in their initial phases don't actually get followed up on, don't actually go into practice. So only about 14% of them get used. Well, this is a big problem, right? Because one, it's taking a really long time, and a lot of potential benefits for people actually aren't getting used. And if they are getting used, they're being used, ages after it would actually be useful to people. So a common example of this is use of low-dose aspirin in preventing cardiovascular disease. It took about 20 years from realizing that this is a potential intervention for improving health and preventing heart attacks to actually it being used in regular clinical practice. Well, in that 20 years, a whole lot of people who potentially could have benefited from this were at greater risk, and many of them died as a result, right? So that's a big deal if you have a really slow progression to actually creating effective public health interventions. So what's going on? Well, the real problem here is that these 1970s style public health interventions are designed to be efficacious. And what efficacious means is that they are usually created in these tightly controlled situations. So what that means is they're created in situations that are essentially ideal conditions. So for example, a lot of these interventions in their initial creation is with a target group of people who are really very interested in doing this intervention. They're not like normal people. They tend to be more educated. They tend to have more, to be richer, right? So these efficacious interventions, which often are very intensive and have a lot of resources devoted to them, when you take them and you try and use them in the real world with a wide range of people in the population and clinicians who may or may not be trained to use it, well, it turns out that they don't work very well. And as a result of this, a lot of these interventions that are designed in these sort of perfect ways actually fail. And so what we see in public health is this turnover, this churning of people banging their heads against the wall because they keep on trying things and they keep on not working. And, people going here and there, trying out new things and just not having this process to actually help us to improve health overall. So that's the real challenge that we were facing. And this was recognized at a national leadership level. And a group of folks said, all right, so why is it that public health interventions are not working? So I will say, to begin with, there's actually a lot of reasons that public health interventions often don't work. For example, they don't engage with communities. They may fail to consider the political implications of it. There's a lot of reasons why you could fail in terms of a public health intervention. But what this group came up with was that these public health interventions aren't really considering how to take something that's that you try out in an efficacious and an ideal circumstance and turn that into something that's actually useful in the real world. So Glasgow et al. Created this framework, which is called the REAIM model. So what this essentially argues is that there's 5 components that really determine whether or not a public health intervention is actually going to be useful in real practice. So it starts out with the idea of reach. Reach is essentially measuring the extent to which a public health intervention will reach a large number of people, right? There are certain interventions that don't have very high reach because they're very expensive and you have to focus them in on a very small number of people. Whereas other interventions, for example, internet-based interventions, are capable sometimes of reaching a whole range of different folks. And there's different strategies, and each of them have their advantages and disadvantages. But the question here is, how many people are actually getting access to this public health intervention? The second question is effectiveness. And effectiveness is the actual magnitude of the impact of this public health intervention on the health outcome that you're interested in. Okay. So effectiveness is different than efficacy, and I will talk about that shortly. But the key point here is that you want this intervention to be effective in the general public, for the general public in the real world situations. So these two things, reach and effectiveness, are really focusing on how the intervention interacts with individuals, with people that are targets of your population. But there's another set of components to having intervention be useful, which are also important to consider. And this is the aim component to re-aim. So one question here is a intervention set up so that it's easily distributed to other organizations? So some public health interventions are very specific to, the clinic that you're working in or the specific location that you're working in. Well, if it just stays there and it's not adopted by other people around the country or around the world, well, then it's possibly not very useful. So paying attention to the extent to which and ways that you can facilitate and improve the distribution of this intervention is actually important when you're designing a public health intervention. Another question is, how is that public health intervention implemented? Well, you can create an intervention, for example, teaching people how to effectively brush their teeth or something like that. Well, when it comes down to it, if dentists don't know how to use that intervention to teach people, and they do it in widely different ways, well, it's going to be very hard to measure and determine whether or not you're doing it right. It's going to be very hard, and it's going to be hard to see why some interventions succeed and some interventions don't, right? So having consistency and quality in the way that an intervention is exercised is actually a really important component to considering whether or not this can be done. And part of the way to do this is actually to have, for example, a manual that tells people exactly how you can actually do this and implement it in a high quality way. And that can help clinicians around the country, around the world, to do this in a consistent way so that we can figure out systematic ways of improving it. The final component is maintenance. So some things are really hard to maintain over time and other things are relatively easy. Now, if you do a new intervention, but it costs a whole lot of money, well, it becomes hard for an organization to continue pumping money into that intervention over time. So really thinking beforehand, how likely is it that this intervention is going to be easy to maintain by an organization? All right, so I'm going to focus here a little bit more on the idea of reach, effectiveness, and efficacy. So again, when you have these efficacious interventions that face real-world situations, we find that they tend not to work very well. So efficacy, again, is the idea that it's this sort of the extent to which something works in sort of ideal circumstances. Effectiveness is the extent to which something works in real-world circumstances. Okay. Now, what it turns out is that the relationship between efficacy and effectiveness really very often depends on the reach of an intervention. How many people are actually accessing a public health intervention? So again, when we break down efficacy versus effectiveness, you're talking ideal circumstances. You're more effective, you have higher efficacy when you're really intensive and it's a very potent sort of intervention. They tend to be expensive, costly because they are so intensive. They tend to have narrow reach because you don't have enough resources to provide this to a whole lot of different people. And it might not just be money that it costs, it might also require a lot of resources, for example, a lot of time by clinicians or other people who are doing this intervention. And because of that, it can be tough to sustain over time. Whereas effective interventions tend to be more of a real world situation, low dose, and low dose here means that it might not be really intense. You might have just a flyer or something like that that's handed out. That would be a low dose intervention. But having broader reach, being less expensive, and not requiring as many resources and effort to sustain it over time. Okay, so that's really the breakdown there of efficacy versus effectiveness. I'll give you some examples. So think about type 2 diabetes. Again, type 2 diabetes is really common in the US population. About 35% of people will get type 2 diabetes within their lifespan. So it's a pretty serious health condition. It has a wide range of different health impacts that are substantial for folks, right? So we want to create public health interventions that can actually help people. Well, imagine that you have a group program. Now, this is actually pretty common for people with type 2 diabetes, but group programs are programs where you might bring people in and you would talk to them, counsel them about how to think about their diet, how to exercise. You might follow up with them many times over the year to sort of make sure that they're doing this. You might provide extra resources to them. You might teach them about the importance of taking your insulin regularly. So this is something where you might have a clinician, a health educator who's doing this. You bring people into the clinic to do it. So it tends to be, there's a few different elements to it. So one is it might actually be quite have really high efficacy, right? So it might be a situation where if you did all these things and you brought people in, well, it might even have an 80% efficacy in terms of people adopting the behaviors that you want to decrease the risk for type 2, for the negative impacts of type 2 diabetes. However, it's likely to have a much smaller reach. And the reason for this is that, one, you're not going to have enough money to do all these things. It costs a lot to have a clinician provide all this information. It costs a lot to use clinic space to do this. And it also means that certain populations this might be less accessible. Well, for someone who doesn't have a lot of power in the work where they work, the idea of coming into the clinic for 10 different sessions might be impossible for them. If you're a working single mother, for example, right? You might not have time to come and do this. So you might also narrow the reach in terms of who can actually access these resources. And we find for these high efficacy interventions, it's quite common that you have people who are excluded from that very not infrequently upon lines of power and access, right? So the point here being that you have a high efficacy group program, but it has low reach. Well, if you multiply that out, 0.8 times 0.1, well, you have a rough effectiveness of 0.08, right? Because you're just not reaching as many people, even though it's making a big impact for the people that it does reach. Well, let's compare that to a web-based program. So here you have a training that's online that teaches all these different things. Someone gets diabetes and you send them a link to this and say, hey, you need to view these video lectures and that will help you to manage your diabetes better. Well, in terms of the efficacy, it might be substantially lower, right? It may actually be the case that people don't use that information as well. They don't understand it as well. But it might have a much higher reach, right? So you might get, because it's easier to go online to actually learn about this information, your reach might be 50%, for example. So a lot more people who couldn't come in regularly to the clinic might actually be able to use that information. Well, if you multiply that out, even though you have a relatively low efficacy, when you think about the population, the larger population that it reaches, well, it actually turns out to have a higher effectiveness than the really intensive group program, which is sort of an ideal circumstance, but turns out to actually be less effective overall in a real world setting. All right, so this is just some information to help you understand the relationship between efficacy, effectiveness, and reach. All right, so let's return to the idea of assessing likely impact. Again, adoption, implementation, and maintenance are also really important to thinking about these interventions, because once you get past the reach and effectiveness, you also want to make sure that this is an intervention that other people can use, right? So if it's an intervention that just focuses on one person who just happens to be really good at convincing people to adopt certain diabetes behavioral interventions, well, you can't clone that person and put them in every clinic around the country, right? You want it to be something that as many people can use as possible, right? And that it can be maintained over time. So let me just show you a chart that indicates what this might look like in these types of situations. And this is an example from type 2 diabetes. So again, your reach might, if you compare an interactive technology like a web-based program versus in-person counseling, which is in blue, red is the technology, and blue is the in-person counseling. Well, the in-person counseling is going to have a lower reach than the interactive technology. Efficacy is lower, probably lower for the interactive technologies. But the truth is that there are certain advantages to some of these platforms that have high reach. So maybe if we did a better job, maybe these technologies can be improved. Adoption, well, adoption is something that might be a little bit harder to do across different locations in terms of technologies. This was actually created in 1999, but now actually transferring electronic technologies around to different locations is actually much easier. So I would suspect currently adoption is actually probably higher for these interactive technologies. When it comes to implementation, well, one of the questions is, do you implement it in the same way with consistent quality? Well, if you have a online program, what's going to be offered in exactly the same way every time that you offer it, right? Because it's all hardwired. Whereas for the in-person training, well, if you have a different counselor who's doing that counseling in different sessions, well, some of them are probably going to be really good, some of them aren't, some of them might be well trained, some of them might not. So in some ways, some of these high reach approaches can actually be very useful in that context. And then overall maintenance, well, for an interactive technology, you just have to pay the web hosting fees, right? That's, some $100 per year. But for an in-person counseling session, well, you're talking about someone's salary. You're paying someone $50,000, $100,000 per year to keep on running that program. And you're having to keep on maintaining space for that program, right? So that's the difference that you see in terms of maintenance, right? So point here is that overall, this balance is going to shift, and there's real advantages for a lot of new technologies and new approaches for taking advantage of reach and efficacy and the other components of re-aim. The other thing that I just want to say with respect to interventions in terms of what we know about them is that the truth is that public health interventions actually very often work best as combination of different approaches. Okay. So what you often see, so if you think about smoking, for example, well, if people try and quit smoking cold turkey, just stop, well, it turns out that they typically don't succeed in terms of maintaining that. Only about 5% of people who quit in that circumstance actually succeed in maintaining that over time. So what we find is that when you start adding in these interventions, that those rates go up. For example, adding Nicoderm patches, for example, has a pretty good impact, somewhere in the 10 to 30% range in terms of people being able to quit smoking. So that's a substantial improvement in this. But if you start adding in other things to that, well, in combination, you can increase the potency of your effort. So if you, for example, in addition to giving them Nicoderm, you give them flyers which teach them about different types of approaches to quitting smoking, maybe help build confidence. You also might have people who call them after they start quitting just to check in with them and train them on how to do this, how to use a patch, how to think about the struggles that they're going through in terms of quitting, and to provide them with social support. Then you might think about having someone's healthcare provider check up with them regularly after they've learned that someone has decided to quit smoking. Or you might think about doing things to try and help them change their environment or what they're exposed to. So, for example, convincing them to maybe not go outdoors and stand with other smokers, for example. So using all these different things together has actually been shown to actually be more effective in terms of helping people to address a public health issue. So think about creative ways of combining strategies to improve impact. All right. So this lecture was really trying to talk a little bit about the ideas around the different ways that you can focus public health interventions, whether you want to consider focusing on individuals or communities, whether you want to focus on upstream determinants versus focusing on people who already have a disease or maybe are just exposed to that disease. And then think about the many different strategies that you can use in public health to address change people's behaviors or help them to avoid risks of various sorts. We also talked a little bit about the strategies are used to develop interventions and how very intense approaches often when they meet the real world aren't terribly effective. So we talked a little bit about REAIM and the strategies that you can use to think a little bit about how you can carefully tailor an intervention to actually have the biggest impact for people. So thank you very much for listening. I hope this was helpful, and we'll talk more about this later.